Dr. Muhammad. So we're gonna wait a couple of minutes and then we're gonna start. In the meantime, do you have any questions or anything unclear for you guys?
Yes, Dr. Nader. This is Khulud. I'm asking about before you posted or just like some previous personal statements for Dr. Mulham and somebody else, I think. I can find them in the app or where can I find them?
Yeah, if you go to the app, I'm sorry. So if you go to the app here, you go down, you'll find them in the second showcase. That. So click to browse the RAS documents.
Okay. Okay, thank you so much.
You're welcome. Yeah. Any other questions?
And
So
also, question, sorry, the LOR, that's the one you just like did for us. That's need to like update the date like that.
So you need to go to IRAS website and then you can put my name and email.
As a new, okay.
Yes, not the new one, and then send it, and then.
Thank you so much.
Sure. Anytime. So for now, we can start, and then as people will join, they can contribute to the meeting. So I want to just make sure everyone is involved in at least one project. So I'm going to share with you this document. Please share it with all other fellows. So basically what I'm trying to do is I want to put a list of all current projects. So if you look at this list, you'll find the project with the title, what type of things can submit as abstract or not, the leader, and then you're going to talk about who is involved. You can add your name here as team members. If you know what meeting or what journal you're going to submit this, you can just put it here and the progress as far as how far we are doing with the project, so that we can be on the same page. Sometimes we may ask you to put the due date so that everyone will know we are in a rush, for example, to finish the project. And if it's submitted, for instance, you can just write down it's submitted. Here, the link for the document, if you submit a document or if you are working as a team on a document, you can click on that and you can go to your document. So you can add the link for the team here. I'm going to share this video on the so if you can, while we are in this meeting or just after that, you can just please add your name. If you are working on a new project, add that project to the list. Thank you so much. So I think Mohammed Muqdad is going to lead this meeting. Is Muhammad here or the team? I don't see them. Anyone in the pink team that is ready to walk or ready to present? Okay. If not, then we can work on some of this. So if I go back to the document that I just shared with you guys. So the first project was about the inflammatory bowel disease, and that was submitted. So if the team is involved, you can add your name here. Why don't I give you 5 minutes to look at this document and maybe add your name or your project if it's not listed here.
Hello, everyone. Assalamu alaikum.
Walaikum salam.
Eid Mubarak to all of one of you guys. I hope you can clearly hear me and see me as well.
Yes, Dr. Muhammad, can hear you and see you.
Yes, we do.
Okay, thank you so much. So, can we start?
Yes, Dr. Muhammad, go ahead. We were just talking about the document that we are trying to update the projects and the teams in this project. So we'll talk about that later, but now you can start. Thank you so much.
Okay. Thank you so much, Dr. Nader. Again, Eid Mubarak to all of you guys. My name is Dr. Mohammed Maqdad. I'm the team leader of the PINK group, and today I'll be presenting and moderating the meeting. Now, if you allow me to share the screen.
Go ahead.
Yes, please.
Thank you. Can you guys see the screen clearly?
Yes, it's clear.
Good.
Yes.
Good. So today we will talk about the colorectal cancer screening. Just for a while, I need to. So the agenda for this presentation will start with the objective, facts, statistics, risk factors, colorectal cancer screening, and guidelines. The objective of this presentation to review the colorectal cancer epidemiology, risk factors, and burden upon the healthcare system nationwide. Also to review the impact of colorectal cancer screening, to review the colorectal cancer screening modalities, and to review the latest guidelines of colorectal cancer screening. Let's talk about some facts about colorectal cancer, why we care a lot, why physicians cares a lot about colorectal cancer. Because it's the second leading cause of death from cancer in the United States, and it's also the third most common cancer worldwide, estimated that the cases for colon and rectal cancer to be 1.9 million cases. One more data between 2014 and 18, the number of new colorectal cancer cases in the United States slightly decreased in patients above 50 years of age. However, in patients younger than 50 years of age, the rate slightly increased. From 2015 to 19, deaths from colorectal cancer declined slightly each year because of early screening and early intervention. One last thing, colorectal cancer is found more often in male compared to female. Here, let's see the epidemiology, or per se, the incidence rate of colorectal cancer in the United States. Here we can see the dark blue colors represent the highest incidence rate of colorectal cancer in the United States, where almost 3,000 to 15,000 cases annually were reported. The latest data in the United States were reported in 2019. I hope you guys can read this text. So the United States, 142,000 new cases of colon and rectum cancer were reported, and 51,896 people died of this cancer. And also for every 100,000 people, 36 new colon and rectal cancer cases were reported and 13 people died. Some more statistics about colorectal cancer. As we see here, the age more than 50, the incidence and the prevalence increased dramatically above 50 years of age. So age is one of the strongest predictor of colorectal cancer. Incidence increased dramatically after age of 50. And here is some data confirms that most colorectal cancer occurs at age of more than 50, estimated to be 89% of all the cases occurs after 50 years of age. The incidence has increased in those under 50 since the mid-1990s, and this is likely attributed to the unhealthy lifestyle, increase in tobacco use, and obesity. A horrible fact here, unfortunately, roughly 1 in 20 average risk individual will develop colon cancer in their lifetime. Now let's talk about the risk factors for colon cancer, starting with inflammatory bowel disease. Inflammatory bowel disease significantly increase the risk of colorectal cancer, especially when we are talking about ulcerative colitis more than Crohn's disease, given that ulcerative colitis is mainly affecting, or let's say it's concise only to the colon. Crohn's disease can skip the colon in some cases. Personal or family history of colorectal cancer or precancerous polyp. Inherited syndromes like FAP, familial adenomatous polyposis, Lynch syndrome. And lastly, some lifestyle factors like lack of physical exercise, the diet low in fruit, vegetables, low fiber intake, high fat and processed meat, overweight and obesity, alcohol and tobacco use. Now the mortality rate, the 5-year survival rate for colon cancer, in stage 1, localized stage, the 5-year survival rate is 91% likely, and among those population, 37 of patients are diagnosed at this early stage. Now in stage roughly 2 to 3, when the cancer spread to the surrounding tissue, organs, or regional lymph nodes, survival rate, 5-year survival rate will be 72%, and about 36% are diagnosed at this stage. The last stage, which is stage 4, the mets to the distant parts of the body, 5 years mortality rate or 5-year survival rate will be 15%, and about 22% are diagnosed at this late stage. Let's talk about colorectal cancer screening, starting with the impact. Colorectal cancer screening can prevent cancer by finding the precancerous polyp in the colon and remove it before it turns to a cancer. Early detection as well will end up with more easily treatable. Also, colorectal cancer screening efforts are directed toward removal of adenoma and sessile adenoma, which is a precancerous adenoma, and detection of early stage colorectal cancer. To date, we have different modalities for colorectal cancer screening, and the gold standard, the #1 modality, is colonoscopy, followed by flexible sigmoidoscopy, CT cholangiography, and stool-based testing, and also blood-based testing. Okay, the approach for colorectal cancer screening divided to 2 approaches. The 1-step, which is the direct approach by colonoscopy. Why colonoscopy is optimal, is the gold standard, because it's diagnostic and therapeutic. Therapeutic, which means to remove any suspicious adenoma or any adenoma to prevent any turning to cancer cells later on. The 2-step approach means initially start with non-invasive procedure, or let's say testing, and if this test is positive, you may refer for colonoscopy for confirmation. For example, the FIT, fecal immunochemical test, sigmoidoscopy, multi-target stool DNA, CTC, which is the CT colonoscopy, virtual colonoscopy, and the colon capsule. Limitation that eventually you will refer the patient for colonoscopy if the test is positive. I think, yeah, we have been talked about. If you give me a minute, guys, I think I confused with some other slides. Just a minute. Yeah, this is the one. Sorry, guys, for any inconvenience. Colorectal cancer screening. Yeah. So, Dr. Nader,
Yes, go ahead.
Can you just give me a minute to look for the file? I think I missed it somewhere. So I'll be back within a couple of minutes, okay?
Sounds good, no problem.
Thank you.
Okay, for the group, do we have any questions about the colon cancer, or from your experience, if you have some clinical experience, any addition, any comments? If not, as Dr. Mohammed mentioned, it's common, and I had a couple of patients with disease, and I followed them after the surgery. So they did fine, and agree with the prognosis as mentioned. So in your practice in the future, hopefully you will have an idea about what's going on, and hopefully you can encourage all your patients to do the screening. Thank you.
So can we move to the proposed projects, Dr. Nader, until I can find the file, please?
Yes. So
Okay,
as we mentioned, so the Word file or Google document file, I hope everyone can contribute to that file. So look at that file and see if you have projects that you are working on. Make sure your name is there. If you are leading a project, put your name, and encourage your team member to put their names as well. And let us know the progress of the project. And the last thing, if you have no projects, you are involved in none, let me know, or you can add your name at the bottom, at the end of that file. Mention that you are interested in any other projects. So we will add more projects in the near future so that people can get involved. Thank you.
Thank you, Dr. Nader. I think I found the file, so may I carry on?
Yes.
Thank you. Thank you so much. Yeah, so back to the approach, one-step and two-step approach. I think we finished with that one. So let's start with the gold standard, colonoscopy. Colonoscopy is the mainstay of colorectal cancer screening. It's the most commonly performed GI procedure in the US, as it allows for not only detection of early cancer, but also a detection and removal of polyp that is predisposed to be precancerous later on. And it's proven that colonoscopy screening reduce the incidence and mortality of colorectal cancer. According to a systematic review, colonoscopy screening resulting in 69% reduction in overall incidence of colorectal cancer and 68% reduction in overall mortality rate. Here are some examples of the colonoscopy finding. Here we may see a small sessile adenoma, and here a large advanced sessile adenoma, and here an ulcerated lesion in the sigmoid. So two-step screening approach. Let's start with the fecal studies. Starting with the fecal occult blood. either to screen annual or biennial, and by studies, it's shown that biennial screening after a couple of years of follow-up, it showed that 18% reduction in colorectal cancer mortality resulted by biennial screening with fecal occult blood. With annual fecal occult blood screening resulted in sustained 33% reduction in colorectal cancer mortality over 30 years. Now, the fecal immunochemical test has largely replaced the fecal occult blood. Why is that? Because it carries a higher sensitivity compared to fecal occult blood. One more thing, that the technique for collecting the sample is much easier, as we need only one sample for FIT compared to the usual practice of three samples of FOBT. One more thing, no dietary modifications or medications restriction are required. Greater sensitivity for detecting colorectal cancer and advanced adenoma, that both higher than both standard and higher sensitivity in FOBT with comparable specificity. Flexible sigmoidoscopy, it allows direction to evaluate the left side of the colon only. It's also similar to colonoscopy, diagnostic and therapeutic, but it's only concise to the left side. According to a randomized clinical trial in UK and Italy, it resulted in reduction in colorectal cancer incidence by 23% and 18%. And according to the US trial, PLCO, colorectal cancer incidence was reduced by 21% and mortality by 26%. However, sigmoidoscopy had declined in the United States due to some reasons. Number one, the infrastructure or the preparation for flexible sigmoidoscopy is quite similar for colonoscopy. Two, it does not examine the entire colon, so right-sided transverse colon can be easily missed. The lack of sedation makes the procedure a bit uncomfortable. The only indication for sigmoidoscopy for those who are unwilling to undergo colonoscopy or FIT test. Now, the CT colonoscopy and the colon capsule. The diagnostic accuracy of the CT colonoscopy, sensitivity ranges between 68 and 89 for lesions more than 6 millimeter, 67 and 94 for lesions more than 10 millimeter. Regarding the specificity, it ranges from 80 to 93 for lesions more than 6 millimeter and 86 to 98 for lesions more than 10 millimeter. One of the disadvantages for CT in right-sided and flat polyp, and it's an operator dependence. Coming to the colon capsule, it has been approved by the FDA for imaging the colon in patients who, or in patients with previously incompleted colonoscopy, or in patients with lower GI bleeding who are at too high risk to undergo colonoscopy. It's like an alternative for high-risk patients. Sensitivity for adenoma more than 6 millimeter was 81. Specificity is or was 93%. For polyp more than 10 millimeter, the sensitivity and specificity were 80 to 97 and 97 respectively. And here we may see the picture of the colon capsule. Regarding the blood-based test, one of the most common used blood tests to screen for colorectal cancer is the Methylated Septin 9. It has gained the FDA approval for colorectal cancer screening in average risk individual in this age range who refuse other modality of screening for colorectal cancer. So what is Septin 9? Is a human protein that encoded by Sept9 gene. It has been shown to be methylated in colorectal cancer tissue compared with normal colonic mucosa. A screening study reported a sensitivity of 49 for colorectal cancer detection and 11 for advanced adenoma. Given the low sensitivity and lack of data to date for this test, it's not usually the optimal in comparison to the other modality of screening. Now let's talk about the American College of Gastroenterology guidelines. Who are eligible for colonoscopy? Well, anybody at age of 50 has to be screened with colonoscopy if no contraindication every 10 years. Or alternative, FIT every 1 year. If the result is positive, we'll refer the patient again for colonoscopy for confirmatory purposes. Here, one step followed by colonoscopy, if positive. Those for people not willing to go for colonoscopy as well, multi-target stool DNA test every 3 years, flexible sigmoidoscopy every 5 to 10 years, CTC or colon capsule every 5 years. Now, a lot of debates has been around for the role of aspirin to protect from colorectal cancer. And the latest update said that low-dose aspirin in patients with high cardiovascular risk, more than 10% over the next 10 years, have to be given low-dose aspirin to target cardiovascular risk and colon cancer protection. Patient has to be at low risk of bleeding and willing to take aspirin for a minimum of 10 years for colorectal cancer protection. Now, people with high risk, we have to define, first of all, who's people with high risk. Anyone with one first-degree relative with colorectal cancer or advanced polyp at age of less than 60, or colorectal cancer or advanced polyp in 2 or more first-degree relatives at any age. Let's say somebody is having 2 first-degree relatives who got colorectal cancer at the age of 70, let's say. So this is a high risk as well. At those population starting at age of 40 or 10 years before the youngest affected relative, whichever comes earlier, the optimal screening modality is interval colonoscopy every 5 years, not 10 years. Also, it's recommended to do genetic testing for those with a family history of colorectal cancer. Now, if somebody is having one first-degree relative with colorectal cancer or advanced polyp at age of 60 years or more, it's not two, only one. At this case, age of 40, starting with age of 40 or 10 years, also before the youngest affected relative. If the result is normal, then resume to the average risk, the previous slide. Now, in people with one second-degree relative with colorectal cancer or advanced polyp, will be treated like an average risk population. In summary, colorectal cancer is the second leading cause of death from cancer in the US and the third most common cancer worldwide. Risk factors for colorectal cancer includes personal or family history of colorectal cancer, IBD, and lifestyle, including environmental factors. Colorectal cancer screening prevents morbidity and mortality. Colonoscopy is the gold standard modality for colorectal cancer screening. In general, average risk population screening must be started at the age of 50 years with interval colonoscopy every 10 years. These are the references, especially this one, American College of Gastroenterology, along with the World Cancer Research, CDC, and Medscape. Thank you for your listening, guys. I'm happy to hear any question. Any question, guys? Thank you so much. So no questions?
Dr. Mohammed?
Yeah.
Yes, yeah. Thank you for that great presentation. I'm just asking
Welcome.
about the screening. Can you go back to the slide of that
The slide, yeah. Okay. So which one?
The time for the
guidelines?
screening, yeah.
The guidelines. Okay. This one?
Yes.
Or the average risk?
Yeah, we can start from here.
Uh-huh. Oh, sorry for that.
Yes, that's it. So we will do a sigmoidoscopy in at which like age group or what the risk factor, and what time you can do that.
At age of 50. All of
Sigmoidoscopy.
those people, yeah, all of those people will start at the age of 50, but those options for somebody who is not interested to do colonoscopy or at high risk, for example, for sedation or so on. So instead, we'll do flexible sigmoidoscopy every 5 to 10 years instead of doing colonoscopy, although it's not the optimum. Many right-sided or cecal mass can be missed easily, but this is an alternative.
Alternative. Okay.
Yeah.
Thank you so much.
You need the next slide as well? Or that's fine?
That's fine. Thank you so much.
Okay, okay. So nobody asked me about the screening modalities or the guidelines for IBD patients. I think this is an interesting topic. I ran out of time, honestly, but I was really interested to prepare this topic, maybe next time, because they have special criteria, special guidelines, especially those, mainly those with ulcerative colitis. Thank you so much, guys.
So
Yeah.
for that, we screen around 8 years after we know for colorectal cancers in UC patients, right?
Well, it seems that you have prepared the step 3 recently, right?
I just gave my step 2.
Ah, step 2. Yeah, good luck.
Yeah,
Best
so
of luck. Yeah.
thank you so much. So it had almost all you presented and it was a nice presentation. Thank you so much.
Thank you. Thank you so much. Yeah, up to my knowledge, like what you have mentioned, that 8 to 10 years, as far as I remember, after diagnosing ulcerative colitis, start with colorectal cancer screening, and you may act accordingly for the interval every 3 to 5 years. It needs a lot of research. Maybe someday I'll
Yes.
present it to you guys. No worry.
Yes, and if
So,
I'm not wrong, so I would like to add, like for those Lynch syndrome and for FAP, you also screen earlier, like around 10 years of age starting in FAP and around 20 years in Lynch syndrome.
excellent. Yeah, exactly. Those population, they need a special screening guidelines. Yeah, you're right. Thank you so much.
Right. Thank you. Okay, thank you.
So,
hello.
yes.
I just have an addition. If I'm not wrong, I think they changed the screening.
I'm sorry, Dr. Dua, I can't hear you properly.
Okay. Just one second.
Dr. Dua, we have trouble hearing you. Perhaps Dr. Batran and then Dr. Khulud. Go ahead, Dr. Batran.
All right, thank you.
Hello.
Hello.
I just have a question. If I'm not wrong, they changed the screening time from 50 to 45.
Yeah, I was going to ask the same question.
Well, that is apparently in the U-World, guys, right? You have read it in the U-World. Because
Yeah.
I've read the same information that they changed it, but according to the latest guideline, 2021 American College of Gastroenterology, it remains the same at age of 50. Maybe some other guidelines they recommend at age of 45. Yeah, that was in my mind as well. I don't know, I couldn't find it in the literature. I may send you the link here and you may read. It's an interesting review for all the screening modalities or all the guidelines.
Okay.
Any
Can
more
I
questions?
can I share you with you the screen? So according to the U.S. Preventive Services, the recommendation is 50, as you mentioned, but also here the mention 45. So it's grade A and then grade B and C. So
is it 50 or 45? Because both are mentioned, right?
yes.
Mm.
So they basically they want you to go by some practice consideration. So it's similar to the I think.
I see. Okay.
Hi, how are you guys?
Hi.
I think early screening, maybe for the patient with a family history of colorectal cancer, they are seem to be screened earlier. I think this is for those patients. This is for those people. I believe so.
That's
you mean the 45 years?
So
yeah, I think so. Yeah, I'm not 100%, but this is reasonable with them.
If I may add.
Yes, go ahead.
Yeah, I think for people with family history, without Lynch syndrome or FAB, I think you go for the youngest person in the family who got the earliest onset, then 10 years before this, because colonoscopy has the ability to detect any lesions before 10 years of progression. So I think if the youngest family member was diagnosed as, let's say, age of 35, then the family close first degree relatives should be screened at 25. This is for the familial, as far as I know. This is not this does not apply to FAB or Lynch, I think.
Okay, thank you.
Yeah.
Thank you for the addition.
So here they basically mention that population who are 45 years of age and they have no symptoms, but they are at high risk, then you can start 45. Then what you mentioned. Yeah. Thank you.
Any further question? Interesting topic, huh? Yeah, it has been mentioned a lot in the USMLE exams. That's why people are super aware of the colorectal cancer screening.
And it's an important topic, and it's if you catch it earlier, then the prognosis will be good for the patient.
Yes, yes, indeed. So, if no more question, I might move on to the next presentation. Okay. May you see in this? May you see the screen, guys? Is it clear?
Yes.
Yes.
Good. So here I'll be talking about the nutrition in geriatric population. Starting with the agenda again, introduction, physiological changes, nutritional requirements, and elderly, a brief about malnutrition in elderly, summary, and references. Just for a while. Yeah, so some facts. The world's population is getting old, and the number of older persons is growing faster than any group of age. One of the key determinants of health in older persons is nutrition, and based to the WHO, older persons are highly susceptible to malnutrition. Malnutrition including not only undernutrition, but also overnutrition, and it's an increased health risk in the older population. Nutrition as well is involved in several disorders in the geriatric population, such as atherosclerosis, dyslipidemia, DM, and hypertension. The nutritional status of all people living in home and the community in India, based on some screening study, revealed that malnutrition is widespread in all people living in geriatric homes. At the old age home resident, almost 19.4% and 57.4% were malnourished and at risk of malnutrition, respectively. Among the old people living with the community, 2% were malnourished, whereas 14.7% were at risk of malnutrition. In South Africa, a study showed that the nutritional status of old people is significantly at low level in geriatric homes. 6% of the older people were malnourished and 47% were at risk of malnutrition. More importantly, that malnutrition is prevalent in older persons, and the more one ages, the poorer his nutritional status becomes. Malnutrition is prevalent in healthcare and especially in ICU elderly patients. Malnutrition in older persons is associated with mental and physical disabilities. As we age, we started to get some age-related changes and diseases, which subsequently resulted in decreased intake of oral food and increased nutritional requirements, subsequently resulted in weight loss, nutritional deficiency, which definitely affecting the age-related changes and exacerbate or advance the existing disease of elderly population. So to break this cycle, we need a good nutrition. Physiological changes in elderly, starting with poor taste and smell, salivary glands gets atrophied, which may contribute to the less taste in the elderly population and also difficulty of chewing and swallowing. Problem with the teeth, gastric function, the stomach and the intestinal peristalsis decreased as we getting old, and the amount of acidity, the amount of the H in the stomach getting decreased, which subsequently decrease the absorption of certain vitamins, for instance, vitamin B12. Some neurological changes like swallowing, as in dementia or stroke patients. Immunity go down, ophthalmic changes, and small intestine. So nutritional requirements in elderly, starting with carbohydrates, proteins, lipids, minerals, vitamins, water, and fiber. Let's start with the carbohydrates. The requirement in elderly reduces, and any alter in any impairment, let's say, or imbalance of carbohydrates intake can result in impaired glucose tolerance in elderly, leading to hypo or hyperglycemia, and also type 2 diabetes. Insulin sensitivity can be enhanced by balanced caloric intake, weight management, and regular exercise. Protein. Protein is the main component of skeletal tissue, and it has decreased with age. Regular intake of daily 1 gram per kg considered to be safe in elderly population. Protein-rich food with milk and curd should be also included. Secondary to decreased appetite and poor digestion, elderly consume less protein, which may lead to the development of edema, anemia, and low resistance to infection. Coming to the lipids, in elderly, it should be emphasized that reducing the intake of saturated fat and instead choosing monosaturated and or polysaturated fat sources. List of unsaturated fat sources like olive oil, avocado, salmon, tofu, and nuts. One more thing, sufficient intake of omega-3 fatty acid may help in certain conditions, such as hair loss, vision impairment, improper digestion, gas, painful joints, and mental health. Now speaking for the minerals, let's start with calcium. Calcium is important to compensate the age-related bone loss. As we improve the calcium balance in our body, it resulted in decrease in the risk of fracture. The daily requirement, the daily safe requirement of calcium is 800 milligram per day. Iron, one of the essential components as well in our body. Low iron might be seen in elderly due to inadequate iron intake, chronic blood loss, such as colorectal cancer, and reduced heme absorption. Vitamin C as well contributes to the absorption of iron. So vitamin C deficiency can lead to impairment of iron deficiency or iron absorption, I'm sorry. The daily requirement is 30 milligram per day. Going to the zinc, deficiency of zinc resulted in delayed healing, decreased taste, and anorexia. The daily requirement is 11 milligram for men and 8 milligram per day for women. Sodium, unfortunately, until now, there is no evidence showed that sodium restriction will delay or prevent any diseases. Nonetheless, sodium restriction may help a lot in limiting the volume overload, such as in patients with heart failure, and it can be used as an adjuvant for antihypertensive medication to control the blood pressure. Daily safe requirement, 2 to 3 milligram per day. Vitamins, the most common one, vitamin D. Elderly people are at high risk of vitamin D deficiency due to the decreased sunlight exposure and decreased renal mass. Dietary supplementation with vitamin D and calcium improve bone density and may protect against fracture in older population. It has been proven that Parkinson's disease patients have a low vitamin D level as well. Other vitamins, C, E, B6, and B12, starting with C. Vitamin C may protect against cataract. Stress, smoking, and medications may increase vitamin C requirement. Vitamin E plays an important role in cellular immunity. Altered immune system can be overcome by taking daily 200 milligram of vitamin E. Vitamin B6 requirement increased in elderly, and liver dysfunction is a risk factor for vitamin B6 deficiency. Vitamin B12 deficiency can lead to megaloblastic anemia and degeneration of the spinal cord. Water. It's an essential for our body, for elderly as it is in young. Adequate hydration prevents kidney function deterioration, especially in those who are admitted in the hospital. It also stimulates the intestinal peristalsis, which resulted in combating constipation. Dehydration resulted in electrolyte imbalance, kidney impairment, mental confusion, headache, and increased risk of infection. Now, let's list some nutritional related disease in elderly, such as obesity, malnutrition, osteoporosis, as mentioned above, CVD, DM, cancer, hypertension, mental instability, constipation, and decreased immune function. So malnutrition. How can we diagnose malnutrition? By a certain criteria, starting with low weight for height or low BMI below 19, decreased subcutaneous adiposity, decreased muscle mass or body lean mass, let's say, and temporal wasting eventually. Incidence of malnutrition, 22 to 43% among hospitalized elderly and 50% among ICU patients. 58.9% risk of malnutrition in elderly with cognitive impairment. Risk of malnutrition among frail elderly is estimated at 46.9%. So it's considered to be high. Risk of malnutrition in elderly, it seems high. However, in the elderly, signs of malnutrition may be noted before hospitalization. Pre-existing malnutrition contributes to the advancement or exacerbation of certain diseases, and there is a proven strong association between malnutrition and mortality. So let's talk about the etiologies of malnutrition in elderly. It's either biological or social. Biological, starting with functional, inability to shop, to cook, chew, or swallow properly, lose of mental capacity, like the one with dementia or Alzheimer's disease, diminished taste, medication side effect, and certain diseases such as malignancy. Social factors. Social isolation in older people plays an important role in the nutritional status. Financial challenges, reduced appetite, and certain diseases such as depression. So how could we assess an elderly with potential malnutrition? Let's say it needs a comprehensive approach where you may start with a full history taking. Start with the diet history, mental health, socioeconomic, physical activities, and then move on to the physical examination to look for any signs of malnutrition, like disabilities, skin turgor, muscle wasting, cachexia, the oral hygiene, for example. Looking for a drug history, medications, like laxative or supplements. Laboratory, serum albumin, help us to estimate the nutritional status in an elderly population, lipid profile, glucose, hemoglobin, hematocrit, iron profile, and vitamins. Procedures such as colonoscopy might be done in an elderly with iron deficiency anemia, for example, because it's considered to be an alarm sign. In summary, adequate nutrition is essential component of elderly population. Elderly are at high risk of malnutrition, and malnutrition contributes to decrease overall health status in the elderly and exacerbation of existing diseases. Nutritional assessment requires comprehensive approach, starting with a full history, including diet, social, and medical history, moving to the physical examination, laboratory, maybe we can use some images, and eventually procedures if needed. Thank you so much. Any questions, guys? Any questions, guys? Let me stop sharing. Thank you so much for all of you for being patient. There are some nice pictures of food. I'm sorry for those who are not getting their lunch yet. Really sorry. Thank you so much for listening.
Thank you so much, Dr. Mohammed, for the great presentation. Any questions or any comments, any addition?
Thank you, guys. Thank you so much.
Thank you. So if there is no questions, maybe Mohammed, can you elaborate about the project that you were working on that you submitted? Can you just share the document? So you submitted to the AMA Challenge 2022,
Yes.
right?
Yes. Yeah.
So what I mentioned earlier is this is the document. I'm gonna share it in the chat with you guys. If you can just add the list of names of the members in this project and other projects as well. I see that at the end there is one person who one of the fellows didn't Majid Ahmed is not involved in any of the projects, so we want him to get involved. So I'm gonna add more projects. So as soon as you hear from the MA 2022, please let us know. Okay.
Okay. Sure.
And other projects as well, if people in the team can add their names, just to make sure. This will help us in the fellowship know what project is going, how is it going, and if you have any need for assistance, you can jump in and help you guys. The other help that we get from this file is that when I write your letter of recommendation, I can see which one involved in which project or submitted to what meeting. So it will be easier for me to write your letter faster without going back and forth to contact you and ask you about which one. Thank you so much.
Thank you. So it seems that no more questions. I can move on. What do you think, Dr. Nader?
Yes. Go ahead.
Okay. So the first topic for today, going to talk about journals, how to choose a journals for publication. Okay, yeah. So first of all, outlines. Why to conduct a research, criteria of choosing a journal, important factors for choosing journals for publications, impact factors, and lastly, Jane. So why to conduct and publish a research? Say something important, share something important, share some knowledge with your colleague, with your peers, with your seniors, share your work, change or influence the practice, perhaps promote any thoughts or debates in the literature, get into a high impact factor journals, which definitely will advance your career and keep your job and eventually make money. So criteria to choosing a journal. What are the aims and scopes of the journal? Any researcher have to ask himself this question. What are the aims and the scopes of a researcher? Because, for example, if I'm going to write a paper on, let's say, inflammatory bowel disease, so which journal is interesting to accept my paper? It's not logic to, for example, submit this paper to a cardiology, strictly cardiology journal. So it has to be something related to a GI, something related to IBD, something related, let's say, to internal medicine, some journals interesting in endoscopy, for example. If the topic, let's say, IBD and microbiota, so microbiota can be published where in any microbiology journals. So we really have to see the scope of the journals, what specific articles they are looking for before thinking of submitting any paper. How the journal published articles that are similar to yours. It's so important to see similar articles, similar topics in the journals. But at the same time, if you may see a similar article to yours, similar study design, similar conclusion, it's better not to submit, because most likely the journal will not accept a repeated article, let's say. But if you have a different conclusion, different study design, different population, let's say, you may easily publish, because you know that this journal are accepting this kind of topic. What are the journal's restriction? Article types. Most high impacted journals nowadays, they refrain from accepting any case reports. Some journals as well are only restricting their activities for review article, systematic review, and meta-analysis. Some journals are interested only in a randomized clinical trial. So you need to see what are the article restrictions in that journal before submitting your paper. What is the journal's impact factor? This is highly significant question and will be answered soon. So 4 things to consider before submitting your paper. Number 1, is this journal is open access? Open access means more readers, more people download your work, and more citation. We are looking for the third one, citation, because the more citation you get, the more valuable you are, and the more valuable the journal will be. Number 2, the cost. Both the traditional and the open access journal may charge some fee for editorial and peer review related cost. And that cost is named article processing charge. It varies a lot, from $8,000 to $5,000, which is huge, to be honest. $5,000 for submitting a paper. So this might limit some researcher from submitting the paper there. Number 3, the impact factor, because as mentioned earlier, the higher the impact factor, the more valued the journal. The speed, this is so significant, especially in our cases, guys, IMG, because we have a deadline for the match. So we are looking for the journals who are accepting the paper quickly. It named that the speed from submission to first decision. And this is a very important rule in most of the researchers. According to one observational study, 80 to 85% of authors believe that this speed is very important role in their decision of where to publish. Basic questions before you submit. even not before you publish, before you submit your paper. So ask, is it a peer-reviewed journal? Is it focused to the work you are doing? Is it related to a GI topic, to the cardio topic, to geriatric topic, for instance? Who's the audience? If you are doing some research on vitamin D, so a journal of a surgeon will unlikely to be interested in your topic. Know your publisher, your scope, indexed and is it indexed and abstracted? So if it's indexed, where? This is a very significant question. Is it in PubMed, Web of Science, ResearchGate? Who owns it? It's not really matter to personally to me, to be honest. Impact factors, and you may find the impact factors by the journal citation reports, review of journal acceptance and rejection rate. You may add here the time where they decided whether to accept your paper or not. I have submitted one paper to the Cleveland Clinic Journal more than 1 month, and they didn't reply until at this moment. So let's talk about the impact factor. The impact factor is a measure of the frequency with which the average article has been cited in a particular year. It has used to measure the importance or rank the journal, calculating the time its article are cited. Any journal with impact factor is considered to be a good journal. Yes, this is right, because a lot of journals, they don't have even an impact factor. Social science journals rank lower in impact than science journal, and for sure, the higher the impact factor, the more valued the journal. Again, how do we find it? Use journal citation reports, and this is the link. So how is impact factor calculated? It has been calculated based on a 2-year period and involves dividing the number of time articles were cited by the number of articles that are citable. Here, I think they made it much easier for us. For example, calculation of 2010 impact factor for X journal. So letter A is the number of time articles published between 2008 and 9 were cited by index journal during 2010. Letter B, the total of citable items published between 2008 and 2009, divide A by B. In 2010, this is the impact factor number. This is the latest updated highest impacted factor journals nationwide in 2022, starting with the Cancer Journal for Clinician, 286. This is extremely significant, guys. The Lancet, number 2, 202, and number 3, NEJM, New England Journal of Medicine, 176. This is the first 15 journals with high impact factors. Let's talk a little bit about journal author name estimator, which is Jane, known as Jane. It's a web-based discovery tool that can help match you up with journals where you could potentially publish. Also looking for journals publish works similar to your own. Jane is copyrighted by the Biosemantic Group and funded by Netherlands Bioinformatics Center. Jane pulls its information from the PubMed platform. So if you are looking for a journals index with Google Scholar, ResearchGate, this is not the optimal tool for you. This is only for PubMed. Jane is created and maintained by Dr. Martin Schumi, and this is the link for Jane. Now let me open the Explorer for you and show you Jane, how it works. Can you see the screen, guys, now? Is it clear?
Not yet, Mehrdad.
Okay. Okay, I will stop and share again. Now, can you see anything?
Yes, it's now visible.
Okay, thank you. So this is the website of Jane, journal author name estimator. It's a good tool to look for any matched article, authors, or even journals to your topic. For example, let's say ulcerative colitis, and you may go down if you want to find journals, authors, or articles. Let's start with journals. Here are the listed journals with the same interested topic. The orange tag mentioned the high quality open access. So you may easily look for the open access journals instead of open individually. The blue one, this is cited by the PMC, and the green one by the midline indexed. So for high quality journals, look for the three colors combined: the yellow or the orange tag, the green, and the blue one, because some predatory are being indexed with PMC. So be aware, guys, with only PMC. It's better to choose the one with midline index, high quality, and PMC as well. Here we may look to the article influence. The article influence is basically like the impact factor, but it's for the article itself. It's not for the journal. It defined as measures how often articles in the journal are cited within the first 5 years after its publication. Okay, and here you may, for example, let's say here, show the article. It drops you directly to PubMed. Okay, let's try vitamin D and look for authors who are interested in vitamin D. Many authors interested in vitamin D. You may or you may not find the email. I'm not sure if you can see the screen here. These are the listed emails for this author. So you may contact him for collaboration, let's say, for review, for assessment, anyway. And here again, show the articles. Let's go again to look for, what can I say? Megaloblastic anemia. Megaloblastic anemia. Okay. Let's find some similar articles. And here the blue tag giving you the approximate similarity to the topic given. You may search and find citations as well. This is a great tool to find a citation for your work. Again, if you click show extra options, you may make it more concise to, let's say, English language. I want only meta-analysis. Let's make it no preference for the PubMed Central. Yeah, let's keep it in open access journals, English language, meta-analysis, and let's say review. Systematic, I'm not seeing systematic review. Anyway, find articles. The best way to look for references directly to PubMed. Directly to PubMed. Again. Finally, you may use the keywords if you have a long topic, for example, and you may look for a keyword. So let's say, for example, Crohn's disease. And let's see who's interested in Crohn's disease. Easily, you may find them, contact them. This is the email. This email address is not found. So up until here, guys, I think I'm done with my presentation today. I hope it's useful for you, as it is for me as well.
Thank you so much, Dr. Mohammed. I really appreciate this. Is very informative and to the point. So the last tool that we mentioned, Jane, we use it and it's very helpful as far as how you want to submit to a journal. So you identify which journal, and then you can look up that journal, the requirements and the author information. And then if you think it's matching what you are writing, your manuscript, then you can go ahead and start sending them the manuscript, and hopefully they will accept it for review, and then you can make the changes and send it to the journal again. So we did this during our last, I think that's 2 years ago, our last paper. It was a big or important topic, and so they accepted it after some revision. So this is how it goes. The easiest way I can show you, for example, let's see. So if you go to the website, you go to the journal finding. So here you can insert the abstract. What I can do is, let's see, you're going to start sharing, and then for example, one of the abstracts that we were just talking about, the isotropin, you can copy all this. You can copy the abstract that you wrote. For instance, this is the one we submitted of Muhammad and his group submitted. So you just write write the abstract and the production method and so forth. And if you hit find the journal, it will match most of the things. So the American Journal of Gastroenterology is a big one, and it has a good influence of the impact factor. So, and then you can select whichever other option that you want to do. For example, this one is also important. So
Excellent.
this is how you do it, and you start with one journal at a time, and then you submit, see if they accept. If they don't, then you go to next journal and do the same. So hopefully it will help you guys down the road.
Thank you so much, Dr. Nader.
You're welcome.
Thank you so much.
Thanks. Any questions or any comments, any suggestions, any addition to what Mohammed mentioned in these topics? If not, I'm gonna just share with you one of our faculty colleagues here at NSU. He works at NSU and in Grand Rapids. So his name is John Mulder. What he does, he sees patients who need some palliative care or hospice care, and he wrote an article just a few, I think, yeah, 2 weeks ago. So I just want to share with you that. So mainstream medicine must embrace palliative care services. This is a new way to consider when you're talking to patients. So my idea is that he wrote this piece and published it, first opinion. Okay, find it and just share it with you guys on the chat. So this is how you can even write some personal reflection or suggestion in the literature and submit it, and sometimes you can get some acceptance. So if you are a good writer, you can just write something and share it with other people through some publication. Sometimes they accept short essays or reflection notes, similar to what we do here. So this is another way of enriching your personal, your CV or application. I'm thinking also of another option. I saw some of you did, and we encourage you to do more and more of this, which is the use of LinkedIn. Platform. This is very good because not only you update yourself and the information online, but also you can see who is following you, what you can mention. For example, instead of just mentioning you are ECFMG certified, you can add also you are a Geriatric fellow or fellow at NSU Michigan State University. This will add some additional qualification for you when people look at your profile. I think it will be good for you, a good impression. So some of you, they have the profile, but they don't add the NSU. Some did, and if you have other, let's say you have green card or you don't need visa, if you mention it, It's just to catch the eye for recruiters or for people who are interested in finding more about international medical graduates on the same page like you guys. So I think it's a good tool. If you don't have an account, please do create one. If you have an account, update your profile, your picture, your subtitle under your name. And if you have any project you are working on, add them so that if, let's say, a residency program administrator or their staff look at your profile, they will have some idea about you if you apply to that program, and they can use this information for your benefit. So in the past, I think some of the fellows did use this service or this platform, and they found it very useful. The other thing is when you get, let's say, Muhammad and his group submitted this abstract to, let's say, AMA challenge, the conference, and if they accept it, you can put on your profile that and updated note that you have published or you have been accepted to present at the AMA or other conference, or if you're publishing an article, let's say in a journal, then you mention that. So it will be also, it's like advertisement to your CV, instead of waiting for events and then going to events and submitting and waiting for the interviews and so forth. I think this is another way, it's a parallel way to use a different approach to polish yourself or the resume of your application or CV, just to put it there. Sometimes people get connected using the LinkedIn, also Twitter, but let's focus on the LinkedIn. I want to hear from you guys who have some experience with the profile, but they have any comments. Maybe I will take on your Amal Alamin. You want to share your experience? I know some of you, they have, for example, Rayan Saleh, you wanna, or Ayat Hashim, you want to share with us your experience using LinkedIn?
Assalamu alaikum. So I joined LinkedIn 2 months ago, and to be honest, it added a lot to my knowledge. I connected to so many physicians, and Canadian and US physicians as well. And I'm already talking to one of the Canadian physicians, and he is introducing me to research opportunities and maybe observe shifts. So yeah, it's really good app.
Excellent. Thanks for sharing. Anyone else that wants to share their experience? Or
Hello, Dr. Nader. Hello,
Yeah.
everyone. I joined LinkedIn about 5 months ago, and the main reason why I joined LinkedIn is to help me with my residency goal, but it helped me with other things as well. So I connected to many physicians in the US and in Saudi Arabia as well. So I got many chances and many opportunities to work in major hospitals here in Saudi Arabia. Also, these hospitals are interested in research, and they helped me a lot. So it was more beneficial than I was thinking.
Sure. Thanks for sharing. This is important also.
Thank you.
Thanks. Anyone else wants to share their experience or add some comments?
I would like to add something.
Yes, go ahead.
On Twitter, yeah, and Twitter. Basically, that's something lead me to MSU Telegeriatric Research Fellowship through a hashtag Twitter or IMG Advocate or Inside the Match. People there are connecting to each other applicants and other mentors as well. Anybody is interested in certain design or type of research like GI, for example, he may post in mid-Twitter and a lot of other applicants will contribute. So what happened that me and Lena connected together to publish a research, and then I've been through to move on to the Telegeriatric Research Fellowship, which is a great opportunity.
Thanks for sharing.
Thank you.
Yes, so there are a couple of other options and platforms that you can use. It will be just helpful if you use these. And so LinkedIn, Twitter, and also ResearchGate. If you don't have an account there, maybe you want to create one and put some of your work, even if it's just the project that you are working on. If you are working on more than one, put all of them. And then when you connect with other fellows, then your work will be noticed and people will look at you as well. When you publish, you can turn that into abstract or paper format like publication. If you present anything in conferences, you can mention that also as oral presentation. So there are ways to improve your application or your resume. So try to use as many tools as you can. Anyone else wants to share any of the tools that we mentioned? Any comments? So if not, we can go to the next topic or any updates as far as projects going on of nowadays. Here, do you have any updates about long COVID? Or any other projects you want to? Yeah, go ahead.
Oh, can you hear me?
Yes, I can. Yeah, go ahead. Thanks.
Hi. Yeah, we're still working on long COVID, both musculoskeletal and cardiopulmonary area. I haven't done much lately, but I was still working on it.
That's it. Excellent. Thank you. Bashar, Dr. Bashar, go ahead.
Hi, Dr. Nader. Hello, everyone. Actually, Doctor, I sent you an email to update you about the project of thromboembolism disease in elderly treated for cancer. Actually, you approved the topic a few weeks ago, but we just have started working on the project yesterday. I sent you an email with list of the names of group participants.
Thank you so much.
And I'm going to keep you updated, inshallah.
Inshallah. Thank you. Thanks for that. Excellent. Any other updates, guys, or questions? All right, go ahead, Maria Muhammad.
Assalamu alaikum. It's me, Manhal. So yes, my daughter changed her name, so I'm sorry for that.
I didn't want to.
Yeah, my daughter was using the was using the Zoom, and she just changed the name. I'm so sorry.
That's fine.
Yeah. Yeah, I sent you an email like before Eid about our projects and the names of all participants, and I'm just waiting for your comment and if you have any advice or any comments. So I'm waiting for your reply
So you mentioned about the number, total number. We said about 10 or like less.
Okay.
So if you have the group ready, you can.
Yes.
Yeah. So go ahead and let me know if I can be of any help.
Okay, you're right. Thank you so much.
Any other updates or any other comments? If not, and then we can talk about I sent you an email a few weeks ago, and I want you to practice on presentation using the Coach, Microsoft Coach tool. So I hope you are going in that direction. I know last week and and some of you are preparing for step 3, so might not be a good time, but try to do your best if you can. If you cannot, please email or contact your team leader. Just mention that you will be excused because of the whatever step 3 or other obligations. But if you can, I think that will be very useful for you guys to practice and then record your presentation of the file that you are assigned. And then each 2 of you will give feedback to each other. So if you don't find or you are not able to give feedback, also mention that to the team leader. They can jump in, and if the team leaders are busy, let me know, and I can give you some feedback as well. So I hope everyone will do some practice for us presentation. That will help you in the future. Okay. I want to mention last part for next coming days or weeks. I want to share with you how to write the case report, or discuss about how you write an abstract for a case report. If you have an idea, go ahead. If you want to learn about that, I can send you some information. Hopefully we can work on that together and practice. And then if you are interested in writing an actual case report, maybe you can find some cases and then you can write these. Sometimes it's easier if you have a case and then you can just write about the case and submit. And we work with older adults, so if we have an older patient that we need to discuss or write about, we can do that, and we have options. One of them is to submit to AGS, American Geriatric Society, or the American Medical Director Association. These they can accept some of the fact as posters, and we had done that in the past. We had a case. If you want to write it, also we can get some journals that can accept some of the cases, and that might not take long time. So, any questions? So,
hello, Dr. Nader. Can you hear me?
Yes. Yes.
Yeah. Hi, how are you?
Very good, thanks.
I had a quick question about, I think at the end of June, you sent an email regarding the INR.
Yes.
So I was just looking at it and I started reading the literature review. started doing some reading from the articles you have sent. I was just wondering if there is groups. I've seen there is group leaders, and we were divided into teams, but I don't know where this project is going. There isn't anyone reaching out, or is there
So,
some?
I'm sorry about that. Yeah, we collected the information about the fellows and divide them into teams. But I want to discuss that also with the teams that are interested. So each team we selected some leader if they can offer that or play that role, that would be great. Otherwise, someone else can take that role. So the idea is to look at the INR and see if we can come up with some questions regarding the use of these new technologies, how
like
we
an
can
app?
measure it, how apps, yes. So if we can get that, like review some apps that are used, and we look at it from an older patient perspective. So what can they do? What can they look at? What can they use the app and
To
something
make
like
it
that.
easy for the elderly.
Make it easy for the elderly.
Yeah. Okay.
That one goal. So if we can get some abstract out of this area, that would be great. The other benefit will be if we want to develop an app, and that can be done easily. You don't have to be very savvy with coding and programming.
Yeah.
Nowadays, we have some simple methods to develop an app, simplified app.
Actually, that sounds interesting. Yeah, when I saw it, I liked it. Yeah.
Yeah. So we can do that using also different tools. We can use, let's say, Google Sheet. We can identify what our variables, and then we can build the app, and then we can test it with some people to see how usability and so forth. And if we are convinced, we can publish it. And you can also put that in your resume or your application that you are developing or develop by the time you are having your interviews and so forth. So this is one area we were thinking. So we have a group of, I think, 3 groups, and divide them about 30 fellows to get all together. So we can use the same method, and we can use it with different languages. So if we build one app, let's say in English, we can replicate the same app with another language, let's say in Arabic or in Hindi or whatever other language.
Oh, so for it to be translation as well.
Yes, so the user, whatever they are using, and they can just look at the app using the language. So that's also a possibility to increase the participant, the number of people who are.
Yeah, that would eliminate the language barrier. And also my second question is regarding the case report, because I'm trying to write one now, and I'm almost done with it. If it's possible, once I'm done, if you could just take a quick look at it and give me your opinion. Yeah, I would really appreciate it.
Excellent.
Thank you.
So we will work on that. So, so in the past, we had a case. We presented that the steroid injection in a patient in a nursing home. So we worked on the case and accepted in one conference. So we can do the same with other. So after you're done, send me the final draft, and then we can work on it. Yeah.
Appreciate it. Thank you.
Excellent. Thank you so much. Dr. Anyone else? Any other questions, comments? If not, right now, maybe in the future, just shoot me an email or contact me, text or call me. And so for the last part, any suggestion for next week group discussion or group human health, do you think you will be able and your team to present regarding the dental topic? Or any of the topics? Maybe she's not with us now. So I'm going to update the app and then contact Dr. Salma. I think she is the team leader for the team. So we will discuss about next week agenda. If you have any suggestions, please let me know. Thank you so much, everyone. Thank you, and I wish you all the best. Good luck, and have a wonderful day or night. See you next week.
Thank you.
Thank you, Dr. Nader, and thank you all here.
Thank you so much.
Thank you, Dr. Nader.
Thank you.
Thank you.
Thank you so
Thank you,
much.
Dr. Nadir. Thank you, everyone.
Thank you, Dr. Nadir.
Thank you so much, Dr. Nader.
Thank you. Enjoy the rest of your day.
Thank you so much.
Thank you, Dr. Nader.
Bye.
Thank you, Dr. Nader.
Thank you. Have a great day.
Great night.
Thank you.
Yeah.